Hello, I'm Kathy Clark, the IAM USA president. We are grateful for Pulsera's support as a powerhouse sponsor and appreciate the value they bring to our audience. We are IAM stronger thanks to this connection. Please enjoy their content on today's emergency management and healthcare leaders are using modern technology for patient tracking and response management around pre-planned events and major incidents. Enjoy, and I'd like to pass it now to Kenzie.
Thank you so much, Kathy. Hello and welcome, everyone. I'm Kinsey Clarkson, Product Marketing Specialist here at Pulsera. Thank you for taking the time to join us for this exciting webinar. In today's presentation, Leveraging Technology and Hazard Response, Advancements and Future Trends, you'll learn how new advancements in communication and patient tracking technology are transforming emergency response capabilities. We have an all-star lineup today, and I'm excited for you to get to hear from them. So without further ado, let me introduce you to our hosts. Brandon Means is the Vice President of Medical Operations at Pulsera, and Kate Leatherby is Pulsera's Sales Vice President for the West. And our special guests today are Dr. Stein Bronsky, who is the Co-Chief Medical Director for the Colorado Springs Fire Department, El Paso County AMR, and El Paso Teller County 911 Authority in Colorado. And Hillary Watt, who is the CEO, CFO, Governmental Affairs for the Coastal Bend Regional Advisory Council in Corpus Christi, Texas. And with that, Brandon, I will pass it off to you.
All right, thank you, Kinsey. And welcome everyone to our webinar. Before we jump in and start talking about leveraging technology for communication during a hazard event, let's learn a little bit more about the respective regions that we'll be discussing today from Hillary and Dr. Bronsky. So we'll start off with Hillary. If you could just tell us a little bit maybe about yourself and about the Coastal Bend RAC.
Absolutely. Good morning. Thank you for having me. The Coastal Bend RAC is one of 22 RACs in the state of Texas. They were implemented by the Texas legislature in the early 90s. And they are also governed by the Texas Department of State Health Services. We are a 501c3 organization. I have been with the RAC for 14 years now. Have seen my fair share of emergencies and disasters, the most prominent being Hurricane Harvey back in 2017. We work with all of the healthcare system moving parts and stakeholders, so hospitals, EMS, nursing homes, home health, all of our emergency managers here in the Coastal Bend, the Texas Division of Emergency Management. And really what our common goal is, to reduce death and disability by having a coordinated and efficient regional system of care with plans for not only blue sky days and disaster days. So in our 12 area county, which is RAC U down there in the Coastal Bend on the Gulf of Mexico, we have a couple of very urban counties, and the majority of our other counties are very rural. So our level 4 trauma facilities out in the rural areas are instrumental in patient delivery and patient care, stabilizing those patients and getting them to one of our level 2 tertiary facilities. We have about 20 EMS agencies and about 10 trauma hospitals, 2 of those being level 2s. And that's it.
Thank you, Hillary. And now we'll just hear from Dr. Stein Bronsky. If you want to tell us a little bit about the area that you work in.
Sure. Thank you very much for letting me join today to talk about what we believe is a really important aspect of our system. I am from Colorado Springs, and that is the main urban area within our county. We have 2 participating counties that are long-term participants in Pulsera. However, we actually are bringing on 3 other counties with a few other hospitals as we speak. And that comprises an area of our RETAC, our single RETAC, which is the equivalent of the RACs in Texas. We have 3 main healthcare systems, at UC Health and Centura and Children's Hospital. We have 47 now. Just last week, another one, so 48 fire and EMS agencies, and we have 8 hospitals.
All right. Well, thank you guys for that overview. It's nice to understand a little bit about the regions that we're serving and operating in. So without further ado, let's just jump right into the topic of the day. So to start off, I'd like to pose a question to both of you. What were some of the biggest challenges, speaking of communication, what were some of the biggest challenges that you and your teams were dealing with that led you to come to the decision that you needed a new way of doing things, specifically the way you communicate? So Hillary, we can start with you and then we'll move over to Dr. Bronsky.
Yeah, absolutely. Thanks, Brandon. During the peak of the COVID-19 pandemic, we had a very major surge of patients in the El Paso area. In Texas, we have teams that are comprised of the Texas Emergency Medical Task Force. The task force deploys to affected areas during disasters and emergencies. So we deployed a bunch of people over there, predominantly medical incident support personnel. And they were there to assist the Regional Medical Operations Center that exists with the RAC and the RAC stakeholders to manage the load balancing of these patients. I believe there were around 800 patients that we needed placement. And if anybody knows where El Paso is, it could be as well be on the moon, because when you're thinking about trying to transfer patients from El Paso by ground to Dallas, to Houston, you're talking 7-8 hours. And some of these patients were extremely sick. So the majority of them were actually moved by fixed wing. But typically we were using, I don't want to say an antiquated system, but it was a system that existed within WebEOC, and it existed predominantly for the purpose of evacuation during disasters. And it was called the Disaster Victim Patient Tracking System. And we quickly realized it just was not nimble enough. And the process of the amount of phone calls that needed to be made between the RAC, the Regional Medical Operations Center, the sending facility, the possible receiving facility, there was just so many steps. It was so labor intensive and time consuming. And Pulsera was introduced at that point as a solution. So it absolutely was a godsend. It really streamlined the process whereby, you know, the RAC could start the channel, the sending facility was in the channel, and then, you know, the teams that were there to assist with the movement of the patient, they're in the channel, and ultimately the receiving facilities in the channel. So within this one system, with one platform, everybody involved in the movement of that patient who's either actively moving them or needs to know that they arrive safely at their destination was able to, you know, utilize the system and have accountability for those patients and where they ultimately ended up.
Great. And I would say my answer to this question about what our biggest challenges and what our issues were that we were trying to solve came from the opposite end of the spectrum than what was just presented by Hillary, where we were starting in a very micro environment of trying to solve communication issues within our healthcare system. So, you know, for instance, we believe that the healthcare communication that we had from the hospital, from the field to the hospital, or hospital to hospital, and it was pretty archaic, and it was just accepted as a commodity, almost something that nobody ever even considered could be changed. And we really thought that there probably was a way to solve the inherent problems with healthcare communication, such as we were having problems matching up STEMI clock times and stroke clock times between agencies and transfer to agencies, and then the hospital system. And that makes a difference when you're talking about registries. And we also deal with the same thing that I believe everybody deals with, which is the fragmented and potentially delayed communication system, where it's just a chain link system where somebody from the field gets on a radio and talks to the hospital. They transcribe something and then they send that information to the operator, and then the operator pages out. And honestly, what it is it's just like an adult game of kindergarten telephone, where you end up on the far end of the conversation with mismatched information that was intended to be conveyed from the beginning. And so we had a huge problem with that. And that is the reason that we sought out more modern day solutions to help us mitigate those issues.
Thank you both for framing up, what the challenges were that you're facing, and kind of why you decided to move to more streamlined communication. You both have kind of a different reason there, and so I'm interested in the answer to this question. And Stein, maybe you could answer first. Kind of dovetailing off of what you were just talking about. Why did you choose to use Pulsera? What was it about Pulsera versus the existing methods of communication that you were using, radios, phone calls, and things like that? How did Pulsera help for the problem that you were trying to solve?
Yeah, so we chose Pulsera because we recognized right away that the platform offered pretty much the exact solution that we were looking for to the problems that I just mentioned. With Pulsera, we're able to get everybody that engages with the patient. It doesn't matter if it's in the field, if it's in the emergency department, if it's upstream into service line people, cardiologists or stroke physicians, trauma teams. What Pulsera does is it allows everybody to enter into one single patient channel and get all the information about the patient all at the same time. And so that alleviates the problem of the telephone game I was talking about, so that everybody knows what they're really dealing with right from the source. And it is so much faster communicating instead of waiting for this chain link process to happen that can really delay communication. And so we could get everybody on board. We could build the very specific teams for the types of patients we were dealing with, so that only the right people downstream are informed, and it really helps streamline the communication and consequently streamline patient care.
Great, thank you, Stein. And Hillary, since your experience was different, starting to use Pulsera in the context of COVID, why was Pulsera chosen in your region?
So post-surge in El Paso, when we were first introduced to Pulsera, the state of Texas stepped in, namely the Division of Emergency Management, and they provided the product to first responders in the state of Texas. And that aligned with another legislative mandate that was provided to the RACs, whereby EMS wristbanding of all patients who were transported by EMS to hospitals were to receive a wristband. And Pulsera offered the technology to be able to track that wristband on a daily basis. What was often happening in the state of Texas throughout the continuum of care, especially if you experienced an MVC in a rural area and you were subsequently moved between, say, ground EMS, air EMS, and then to a trauma facility, and then maybe to a rehab after that. The Texas Trauma Registry, you would show up as 4 patients. So there was no singular alphanumeric number that could follow that one patient throughout the continuum of care. So these two kind of happened, and it just aligned that, Pulsera came on the scene in conjunction with the wristband, and it was just like a match made in heaven, because they complemented each other and definitely helped solve this problem. It also speaks to the fact that, EMS are doing this every day. They're banding the patients every day. And then Pulsara was able to, pivot at times and say, well, what if it could do this? And what if it could do that? And so, and then come disaster day, it's just, matter of fact for everybody, especially as a coastal jurisdiction where our goal is to get everybody off the coast if there's a hurricane inbound. And the ability for not only our facilities to utilize the technology, but jurisdictions as well. And I think that really is important.
Awesome. Well, thank you both for those explanations. When we look at daily operations and sustainability of whatever platform and protocol you're using for communication, when we look at things like improvement in patient handoffs from one team to the next or one organization to the next, patient tracking, and even reunification, which I hope we get into in a minute. Let's get into the details of what that actually looks like day to day. So for the teams and the organizations that you both work for, the use of scannable patient wristbands in coordination with the Pulsara platform. This is obviously starting to become the standard of practice, not only for everyday use, but in these patient contexts, but rolling out, regionally or statewide for larger emergency response applications. Can both of you share a little bit more about this? And Dr. Bronski, we'll start with you. If you could give us a little bit of insight on how the scannable wristbands have made a difference in the day-to-day, but also scaled up for any type of surge event, whether that's an MCI, wildfire evacuation, or anything else that you have more patients than you do resources.
Sure. We believe that the wristbands are an extremely vital part of the technology and the communication. I'm going to dovetail on what Hillary mentioned before, which is that depending on how a patient enters into the system and how many times they're transferred among agencies, you can end up thinking that one patient is 4 patients or 3 patients, and it's very, very difficult. I really explain to people the bands, very, very simple concept. Using bands on patients and scanning those in at every transfer, if it's between EMS agencies or EMS agencies to hospitals or hospitals to hospitals, it's like tracking an Amazon package, right? Nowadays, what we do is you can just load up on your phone and say, where's my package? And you can see that it's scanned in here, it's scanned in there, it's now here, and it's going to be dropped off there. And it really makes tracking patients that easy. And I think that most people in this day and age can relate to that concept of how important it is to be able to find out where your patient is. And so what we've chosen to do is put the bands out on a daily basis. We say every patient that EMS encounters that is going to be transferred or sent to a hospital or transferred to another EMS agency, everybody receives a band. And we accomplish a few important things with that. One is what I just mentioned, which is that you can track the patient. You can make sure that you know that this patient who we used to think were 4 patients is really just 1 patient. We can keep all of the original information with the patient, because in the old system, sort of the status quo is that if a patient is transferred from all of these places through agencies and through hospitals, your chances of receiving adequate information about that patient diminishes significantly on each transfer. And so this helps keep all of that information together from the point of origin, which is extremely valuable. The other thing that we think is extremely valuable, and we can't overemphasize this at all, is that putting bands on patients creates muscle memory. And why do we want muscle memory? Because the way that we use Pulsara and plan to use it into the future is that Pulsara is scalable. it's instantaneously scalable, meaning that we can use it for the individual patients that I'm talking about already. But then all of a sudden, if there's an MCI, no matter what size that MCI may be, we want everybody to be banding patients. And we recognize that a universal failure in MCIs is that we expect everybody in our system, be it EMS or the hospitals, to all of a sudden convert all of their operations and all of their thought processes to something completely new in the most high stress situations. And it almost fails every single time. The only way that it doesn't fail, honestly, that I've seen is when you happen to have a drill and then all of a sudden a real MCI happens like the same day and everybody has like, oh, we just trained on this morning and, and you can go do it. But otherwise, you really don't use all of those different thought processes, all of those different triage processes, all of those different staffing processes and hospital availability processes and all of that. You have to switch in the most high stress events during MCIs. But if we're banding everybody on a daily basis, then it doesn't change any of our operations. Everybody does exactly what they always do on a daily basis. And there's no need to switch that thought process. And you can really, really scale it up. We just started putting the bands out into the field, I will mention. And our timing is that, unfortunately, we have so many of these. I'm not sure if people will remember ours in particular recently, but we had a Club Q shooting here in Colorado Springs a few months back. And we had an extremely difficult time tracking patients. We used Pulsera, but we weren't using the Pulsera banding. And so we ended up with the same thing that everybody ends up with, where people are just sent to various hospitals. They may or may not be sent by ambulance. They're arriving by private vehicle. They're arriving by law enforcement. We have no idea where people are. We have no idea, how many people we have. And that's a universal problem. But with the banding, that pretty much resolves the problem. I don't know how many man hours trying to track down all the patients and from that Club Q incident with the same problems that we mentioned before, where one patient was transferred to a hospital and then they were retransferred and you think they're two different patients, et cetera. And it really takes an incredible amount of time to resolve and mitigate all of that and put it all together. But Pulsera with banding, it's just instantaneously done. And also another real important point before I stop is the concept of reunification. Reunification after a mass incident is extremely important and extremely difficult historically. But if we use the Pulsera banding and every patient belongs to a band, then everybody can access all of those patients and you can find out where somebody is in their journey through the healthcare system instantaneously, which helps tremendously with reunification.
Yeah, those are great points and well received. An MCI is difficult enough just when you're doing the same thing you do every day, but just a lot more of it. And so that's not really the time to learn a new technology or a new process. So very, very good points. And to build on that, you talked about tracking patients was difficult for the Club Q shooting, and all those patients stayed in Colorado Springs. I think Hillary probably has a little bit different perspective on tracking patients. As she spoke earlier, patients moving 7, 8, 9 hours away for some instances. And so, Hillary, for you, what are the advantages of implementing this system across your region or even statewide versus just a local initiative?
Yeah, I would echo what Dr. Bronski alluded to there, on the everyday use and the tracking. We utilize it in the same ways. Our facilities and EMS are working together now to utilize for stroke alerts, STEMI alerts, trauma alerts, right? So that's your kind of blue sky day stuff. And then when they get transferred out of region, maybe to a higher level of care, the hospitals and the EMS are using it. So they're able to have accountability for where the patient ended up. I think our biggest thing for our area is when we have evacuations, as I mentioned earlier. So we have a hurricane inbound. Our hospitals all know they're going to use their own contracted transport agencies to transport those patients out of harm's way. They can go into the app, they can create a manifest and band all the patients. And then, of course, EMS who are showing up are already banding patients every day. So it's not something to learn on the day of the disaster. It's, as we said, muscle memory. And then the other portion of that is more often than not, all of our hospitals are contracted with the same EMS agencies to provide that transport during a disaster or an emergency. So that at that point, we would call in state resources. So I think the fact that at the state level, at the Texas Emergency Medical Task Force level, and at the local level, although all disasters start local and end local, we're all on the same page. And I think that's the future, is of us all being on the same page, all utilizing the same technology. The accountability at that point, when you send patients out of region and you know you're sending them to a sister facility, you may be sending them to a medical shelter. You may have a home health agency that doesn't necessarily have a sister facility. So we're talking about not just hospitals, not just EMS. There are many, many agencies and types of healthcare providers that we touch when we talk about these types of scenarios. HIPAA compliance is obviously an amazing feature that it gives the ability in the field for EMS to just snap a picture. If they don't have anything else that they don't have time to fill in all the information. That's the beauty of it. Also, is if all they can do at that point in time, because they're providing patient care, is snap a picture, start the channel, Air Medical's en route or whoever's en route, add them to the channel. Then when time allows, they can go back. We had an MCI, we had a drill recently at the airport, a mass casualty drill. And it just happened that that evening, we actually had an MCI in one of our very rural counties where we only have one level 4 trauma facility in the state of Texas. Level 4 is the lowest level of trauma. So they were able to hire, it was a Greyhound bus and an 18-wheeler. So that bus was full of people and it was 2 a.m. Everybody that responded had been to the training at the airport that day. They were still on shift. They were able to seamlessly get the app out, start the channels, get people triaged, replace these triage tags. There's no real need to utilize these triage tags, as the doctor alluded to earlier also. It's all nimble enough to be able to done within this technology. And so it just provides a seamless way for us to, continue patient care, get them to the right care at the right time, and saves time. It's efficient.
Yeah, that's great information. Thank you both for those wonderful responses. You're both really, kind of on the cutting edge of patient tracking and utilizing technology for that to do things better. And, Stein, you kind of had more of a grassroots approach to changing the way that you communicate, starting in a very narrow way. And then Hillary had a little bit of a different experience kind of from the top down. But I'm always in awe of the folks that we work with as far as the fortitude it takes and leadership to get a group of stakeholders together and help people see that there's a better way to do things. So I'd really like to hear a little bit, Stein, and you can start with the response, but I'd really like to hear how you were able to do that. How did you bring stakeholders together to implement change?
Sure. One of the things I want to mention that you just alluded to, Kate, was that the great thing about this technology is that you can enter into it in many different anchor points. It's not like everybody has to do it the exact same way. There's a lot of differences among communities, among community players and stakeholders. And so this is not a one size fits all as far as where you anchor in and start the process. Hillary in Texas started from the state level and pushed down, and we started from the community level and pushed up to the state level. But it just goes to show that that no matter what direction you're coming from, everybody begins to realize the benefit of this, and then it bleeds into the other areas. I mean, for us, it was up to regionally and state. For Hillary, it was, down into the more regional and local levels. And we all end up in the same place in the end. But we had very, very different anchor points and process initiations. But as far as our community was concerned, we knew that this was going to benefit patients. And so we took a real community look at it, and a perspective that said, we're going to do this for the good of the patients, but to really make this work, we have to have everybody involved. We can't have one hospital doing it and one hospital not. We can't have 4 EMS agencies do it and 16 not do it. That just was not going to work. And so we really got everybody together as a community and all agreed to go into this process. Did we all do everything exactly the same timing? No, but we in general moved together to make that happen. And it was so important not to do it in a silo. It was really important not for like an EMS agency to decide, hey, we're just going to use this. Or one hospital say, hey, we're just going to use this, or a service line. But we needed everybody all together to understand the benefits that this was going to exact if we all work together. And one of the really important things that we recognized fairly early on was that we needed a regional oversight entity in this. And we created something called the Regional Communication Committee. But really what it is it's our oversight, because this is such an integral part of patient care with communication and tracking, that we want everybody coming to the table consistently on a regular cadence to be able to discuss what's working, what's not, how to tweak it, how to make it work better, resolve issues that we may be having, because we're way beyond the point of saying, oh, we think this aspect isn't working, we're going to dump this. No, everybody understands that this is the way of the future, and we need to resolve the issues as they come up. And we do that through a regional oversight where all stakeholders are involved.
Yeah, thank you. I know just from working with you all and participating in some of those committee meetings, how powerful that's been for the region as far as transparency, accountability, and working together as a team to improve patient care in your region. And Hillary, your approach was different, as mentioned, kind of top down. So after the mandate came out, how were you able to get your stakeholders together to implement and kind of embrace the change?
Well, the Texas Division of Emergency Management, in conjunction with the governor's office, they picked up the tab, and they're paying for it for all first responder agencies. So that was huge. The other huge portion of this was leveraging the relationships that we have at our healthcare coalitions here in our regions, right? And as we have with our counterparts around the state. So there's a constant communication. We were able to just, meet with our stakeholders. And to be honest, some of them had actually deployed to El Paso with the Emergency Medical Task Force as medical incident support members. So they were from predominantly, I would say, larger, EMS agencies and fire departments, but they were exposed to and utilized Pulsara during that huge surge in El Paso. So when they came back to region, and then we had our next, meeting of all the stakeholders, and we were able to say, hey, this is coming down the pipe, we should really get on board. Then we had local champions. We had people who had been exposed to it, who had used it, who had touched it, felt it, seen the benefits of it, and were able then to influence, maybe those that were a little more change resistant. And then in conjunction with working with your team at Pulsara and how responsive you were to, you know, marrying up with those agencies who might have needed a little extra help, some extra training, a little more hand-holding, we were able to implement it, you know, throughout all of our EMS agencies. Our hospitals saw the benefits, and then they jumped on at the hospital level, and they're fully committed to it on that end. So I think it really just came down to having the relationships, having the state involved, and again, it more often than not doesn't start that way. So this was just an amazing feat to be able to have the end goal of this going, you know, statewide, and then you have, you know, everybody in the state likewise utilizing the same technology. That's our end goal.
Yeah, change is really easy, right? Yeah, so we all know that change is super difficult, especially, Hillary, you know, on the state level. That's a lot to do in a short amount of time. And it's a pretty big paradigm shift for a lot of EMS agencies and hospitals and regions. And so both of you, how did your teams and organizations, you know, what was the initial response? Did you have, you know, did you see a lot of resistance? Did they embrace it? Did they embrace certain concepts more than the other? Again, you guys took two totally different approaches to this. So Stein, I'd like to hear, you know, specifically about the EMS agencies and the hospital systems. How was this received, just to change the way we communicate in general?
Yeah, so as far as our community was concerned, we had sort of two main pools of entities. We had the pre-hospital, and then we had the hospital entities. We didn't have regional or state to be dealing with at that time. And so when we implemented this, absolutely, I mean, you know, I cannot say that there was no resistance, that it went smoothly in every aspect. Nothing like that, you know, works, you know, quite that smoothly, because it's change, and everybody has resistance to change, especially in a large system. And so we worked very specifically with EMS agencies with their particular issues that they had and their resistance. And then we worked with the hospitals very differently with their issues. And then we also had to bring those two global entities together to recognize what type of just system-wide resistance we may have, and that there were some things that they had to resolve together that couldn't be resolved just in the silo of EMS or the silo of the hospitals. I would say that so many years into it, I think we're almost going on 7 now, that all of we really have not run into any major issues that were not just perceived issues, meaning people would have resistance to change because they didn't like this aspect or they didn't like that aspect. But those were all perceived barriers. None of them ended up to be real barriers that were unsurmountable. And so once we got into a mindset in our community that this wasn't a toy that we were just trying out, and if we didn't like it, we were going to toss it in the trash, we got to a point where we said, this is it. And we know this is the way to go. So bring your resistance to the table. I want to hear it all. We want to really help you resolve all the issues that you have, or the perceived issues that you have, and work with them to make it better and to make them more satisfied with it. And really, in the end, I can say that there's not one entity out there, pre-hospital or hospital or regionally, that has not seen the tremendous benefit that this provides. And that really ultimately just makes resistance melt away.
Great points. I think, you know, the resistance is just to change itself, right? Because the technology is nothing we don't use every day. We're using smartphones in every aspect of our life. Hospitals figured out the wristbands a long time ago, and they've been using those for a long time, right? The the logistics companies like FedEx and UPS, they figured out scanning. They figured out tracking. So these are not new concepts, right? These are things we do every day, all day. What we don't do all day, every day, are use pagers and fax machines and the technology that we've seemed to latch onto in healthcare. So great points. And we've got a few more questions, so we'll hopefully we get through them. But Hillary, do you have anything to add on the change management piece and what helped you guys through that?
Yeah, I think again, relationships, like our cardiology group, we're currently working with them. They have an answering service and they want to do it for STEMI alerts. And so they don't want to give up their beepers, believe it or not. And they're stuck in their ways, but just finding the one champion or the one person that's willing to take time and then, go demonstrate and educate and just stay the course, right? And be adaptable, if they want their answering people service to be trained on it, then hey, you know what, if that's the first step that we can take in that direction, great. The trauma alerts, yes, they've fully on board with using it for trauma alerts and stroke alerts. Also for our EMS agencies, the guys and girls in the field, they're like, oh, it takes too long, is this and this and this. But we started at our regional level a Pulsara steering committee, and so we work in conjunction with the Pulsara reps in our area to again just meet the needs that they have, just like Dr. Bronski alluded to earlier, just meeting them, listening to them, and helping them through that, any challenges that they have. And then again, just having the state support is truly amazing.
Yeah, thank you, Hillary. As a paramedic, I can vouch for that. The new technology in your hands, it's like, oh my gosh, I could just call on the radio, that'll be faster. But what we do see is actually a net time savings once you become familiar with the technology, 30 to 45 seconds to get some valuable patient information. And they're even faster if you're scanning an armband and you're able to send that information to the right people and get your patient to the right care at the right time. So thank you for that. You both have mentioned some different drills that you've been, a part of and some real life incidents. And so I'd like to hear a little bit more about that. And Hillary, you did say something about triage tags. And so if, you could also elaborate a little bit on why the armband has been superior to the tag, and then maybe talk a little bit more about that airport mock MCI full scale exercise that you had mentioned for the audience. That would be great.
Yeah, I mean, I don't know about in your states, but in our state, it is mandated that EMS carry and utilize the triage tags, and they are pretty antiquated and they're clunky and they're huge. You tear them off. We quickly realized that utilizing just the triage tape was great. It works fabulously in the field when you're triaging, an airplane full of people. But then utilizing, the Pulsara app and being able to mark them in the app as, red, green, whatever they are at the time, and then being able to go back. It's so nimble and it's so user-friendly that you can go back in there and change it, in a heartbeat when that person's status changes, or the next person that happens to handle that patient. Now you could change it in the app. So it's just instantaneous and it's updated immediately. There's no messing around with this paper tag that's got blood on it, whatever on it, right? And may or may not make it to, the facility that is receiving those patients. So we've just been amazed at the nimbleness of it and how effective it is with those regard.
Yeah, thank you. And Stein, you said you recently started to deploy the armbands in the region. We participated in a drill with you at the United States Air Force Academy, and they used the triage tags in that event. And then there was a mall simulated MCI that we participated in with a few months ago, and you used armbands. So I'd like to hear your perspective on kind of the difference in those two drills. I think they both went well, but how the armbands were an improvement from the USAFA exercise.
Sure. I think that the difference between those two drills just hits home the same concept that we're talking about. The change is difficult. it's really, really hard to talk to people about ditching a system that they have used forever and ever, like the triage tags and the different colors, and it's just sort of ingrained into people's subconsciousness that they have to use that, and they don't even have a framework to even look at things differently. And these two drills really help demonstrate the difference of that. In the USAFA drill, which is the United States Air Force Academy, we did use the Pulsera tracking, but they also used the traditional triage tags. And I think one of the, and that was really valuable, because we were able to show the military command as well as our local EMS system that one of the first things that they realized was, oh, we didn't really need those, triage tags and all the colors. That just sort of got in our way. It created extra time, extra effort. It wasn't what we were using to transmit information anymore, not easily updated. And so that was very valuable to actually kind of use those two systems put on top of each other for that drill. Then a couple of months later, we had another drill at a mall, which was pretty large, where we ditched all the triage tags and we just went right to the banding. And that was very successful. And I will say that the reason why I thought it was successful is because we use Pulsera every day anyway. And so it was not a new concept to any of the providers. Not one EMT or paramedic was trying to figure out something new or something that they were taught, a year ago and expected to remember in a high stress situation. And so it was very successful using the bands. And one thing that using the bands does is that it allows everybody to see the patients. The hospitals can see them, incident command can see them, people on the ground can see them. Everybody gets a global picture of who exists, what level they are in the triage system, and you can very easily change that, and it's updated instantaneously for everybody to see.
Yeah, that's great information. And Brandon, if you'd like to take it.
Yeah, that's a great point to make, is, patient condition and acuity, it's dynamic. And so when you're putting something that's, put a red tag on someone and they change condition en route, you could apply a different tag, but no one else is going to know that in real time. So the transparency of using a scalable system, that when they do change, or if anything changes, the entire team sees it, definitely of some advantage there. So let's kind of wrap things up on a different note when talking about value achievement and ongoing development of the way that you guys communicate. And so I'm going to ask a question. It's kind of a two-part question. One, where do you see the future of emergency management communication and coordination heading? And what advice would you give to leadership wanting to build a system like this for their city, region, or state? So Stein, if you want to take the first stab at it, and then we'll go over to Hillary.
Yeah, excuse me. I'll answer this very simply. I believe the future of emergency management communication or healthcare communication is what we are using right now, this platform that Pulsera provides, because it is simple to use. It is scalable all the way from an individual to huge mass casualty. And when it's used in everyday operations, then it really is a very seamless way of communicating that won't be disrupted when events change. It also allows everybody to be communicated with at the same time. Which is something that we've never ever had in the past. We completely obliterate this chain link communication that I was talking about earlier, and everybody gets all the information at the same time, and it is very helpful, and it really helps streamline patient care We've proven that with our data. And we can never go back. And that's the way that I see the future. As far as what advice would I give to leadership who want to build a system, I would say that don't try to build it in a silo. Everybody needs to be involved. We have to have it, everybody from the top down be involved, and everybody understanding that this is for the good of the patients, and they need to think a little bit outside of their silos in order to understand that, and the absolute necessity of making sure that whatever communication system we build on a daily basis is just instantaneously scalable seamlessly to any size or type of event.
All right, thank you. And Hillary, do you have anything to add to that?
Yeah, I fully agree with everything just said, and so I won't repeat it. But I do think for our state here in Texas, I think this will likely replace systems that we already have and processes that we already have in place. We're already doing it on the daily, on the blue sky days, but I really think when it comes to the larger scale emergencies, the disasters, the evacuations, especially not only of healthcare facilities, but for jurisdictions also. So I think the emergency managers that I engage with in all 12 of my counties, I do finally think this is going to be the future for them as well when they're talking about mandatory evacuations in their county. Who do they have to account for? They go to the embarkation hub to get evacuated. They're banded, they're scanned, and you know what? They arrive at their shelter in San Antonio or wherever, safe and sound, and everybody is accounted for and can continue to be accounted for as long as they're wearing their band and they're using the technology. Advice for leadership, leverage relationships. Be a champion, find a champion, get involved with your healthcare coalitions. Healthcare coalitions are national. It's a federally funded program, and they're in every single state. And you typically have all of the relevant stakeholders at the healthcare coalitions, from hospitals to EMS to nursing homes, long-term care facilities, emergency management, public health. So healthcare coalitions, definitely get involved in them, and then just work with work with your state and regional and local people, and continue to educate and continue to listen and be responsive to what the feedback is you're receiving. And be patient, because Rome wasn't built in a day, but once they see it and feel it and they realize how amazing it is, they're really going to want to do it yesterday. So
Hillary, I think that every answer you gave today, you said something about relationships. And I think that that is what we should all take home for sure, is that can't be stressed enough. Know your local healthcare coalition folks, your emergency managers. Do frequent drills between EMS and hospitals and anyone else, ancillary organizations that may be pulled into a disaster or a hazard situation. I mean, that can't be stressed enough. In addition to obviously having a way to communicate that's scalable and that provides the muscle memory, that's a piece of it. But we cannot neglect the relationships and the preparation that needs to go into this. So I'm glad that you drove that one home so well today.
Yeah, thank you both for such wonderful answers. I think that, there's probably folks in the audience that are inspired by what you've talked about today. And, the question is always, how do I start? Where do I start? And I think you provided some great advice to the audience in that respect. Now that, we've discussed a lot of different things here, we're running out of time. So I'd like to ask the audience, do you have any questions that you'd like us to address with the group? And
I think we have one question come in. It says, for something like an MCI, can hospitals add patients to the incident? So the answer to that is yes. And it was brought up earlier, when we look at these MCIs that we all see and hear on the news. The Vegas shooting at the concert comes to mind. And they had a very large percentage of their patients that were self-presenters that came in by Uber or loaded up in the back of a truck or something. So in an incident, in a surge event, whether that's an active shooter or a school bus rollover or wildfire, hurricane evacuation, knowing your total count of patients, even if they don't follow all the rules and call 911 and come in by ambulance, that's important. And so in the platform, we have a way for hospitals to add those self-presenters and walk-ins to the incident. So from the scene, incident command can see an active and accurate patient count.
May I, Brandon? May I just add something to that, if you don't
Yes,
mind?
please do.
I think excellent answer, but I also would add what we did for those types of incidents when they self-present to the ERs. We forward deployed a bunch of the wristbands to the hospitals also, so that if they happen to come by POV or law enforcement, any other means, not by ambulance, whereby they would have had a wristband on them, then they have the ability to then band them. So whether they stay there or get transferred out of region to a higher level of care, they're still accounted for and they become part of that incident.
So we have another question here. And Stein and Hillary, I think this is a great question for both of you to answer. How does this work if other agencies around you are still using radios or other systems? Can other fire and EMS agencies and even the hospital system still benefit if they don't use it yet?
I'll answer the first part of that, which is easier for me to answer. We have had a few holdouts, like an AMS agency here or there, or a smaller hospital in a rural county that say that they don't want to use it, and they have all sorts of reasons that they don't want to use it. But now with all of the data that we have showing how much this streamlines patient care and gives us the ability to track patients, we actually can go to those facilities and those EMS agencies in a very, very friendly way. I mean, not ultimatums or anything, but lay it down and say, we believe that you not using this technology is now causing you to operate not at the standard of care that we are accepting in this community, and that we really can show you the benefit to the patients. And we've taken that approach, very kind approach, very collaborative approach with those entities that originally didn't want to use it. And the data is pretty compelling, and we can bring them into the fold is what we've discovered.
I love that, the standard of care, raising the bar in your community, making things, communication better for the benefit of your patients for long-term outcomes and treatment. So Hillary, do you have anything to add to that one?
I would say, leveraging the relationships and the communication with your EMS medical directors. We have a cohesive group here in our area. And there's an expectation from the state level. In Texas, we have GTAC, and that is called the Governor's EMS and Trauma Advisory Council. And they're comprised of different committees at the state level. If something's introduced at the state level as a great idea, it then trickles down to the RACs in Texas. And the expectation is, you're going to go forth and you're going to rally the troops, and we're all going to get on the same page. And I would completely agree with what Stein just said also about patient care. So it's a kind of delicate game of, as he said, being friendly, and it's all in your approach when you go to talk to people. We could certainly change our bylaws at our level and say, hey, because in the state of Texas, if you want to be a designated stroke or trauma facility, you're mandated to be a member of your regional advisory council. So they have to be a member. They have to be a member in good participation. we could easily turn around and say, you know what, utilizing this is part of your good participation, but we don't want to do that. We would rather have a room full of people that talk it through, understand the end goal and the big picture, even going down to the, you know, the folks that are the boots on the ground, making them and helping them understand the big picture, the statewide goal, why this is a good idea. And then you've convinced everybody in the room that this is a good idea. And you've gone from the top down and it trickles down. And you know, in our area, it started, some agencies took longer than others. It came in waves, you know, some were on board immediately, some took longer, just like it has in other areas, and it will. But I think if you take that approach, the friendly, you know, let's do this because it's for the greater good and it will improve all aspects that we've talked about today, then it really becomes a no-brainer. And it's hard for people to say no, because then they become the outlier. And then it's like, why are you still calling on the radio?
Yeah, and I'd like to, I know we're out of time, but I'd like to add something that I think is very important, adding what Hillary said. I view this honestly as a operation or a concept of attraction, not promotion. And we can go out and promote it all we want. But in the end, what's happening in our community is that as we use it so ubiquitously, we have people and entities, behavioral health organizations, other service lines in the hospitals that are saying, hey, can we get on board using this? We could benefit from this. And so it's actually an attraction to them, not us trying to go promote it to them. And that's a great place to be in, kind of the other side of the hill. And that's how I see it moving forward in our communities.
Thank you both. And we do have one more question that I see from Barbara. Thank you, Barbara, for asking that question. And it's about who pays for it. I know we're out of time, and but I think it's an important question. Who pays for it? That's kind of the inevitable question. So if you could just quickly answer that so we can close out.
Yeah, I'll answer. When we originally started, and as of right now, the hospitals pay for this by census. I'm not exactly sure what the formula is, but we are rapidly moving to a place where the state is probably going to adopt this and push it down through the entire state. And at that time, the state will take over all payments.
And I think, Hillary, you had already mentioned that the state, you said picked up the tab and removed that financial hurdle for all of the EMS and hospital entities in the state. So thank you. You had already
Not hospital, EMS, first responder. Hospitals are using it in-house, and they're happy to have this wonderful solution and foot their own bill. But for first responders in the state of Texas, yes, it is just being approved again for another extensions. So,
and I think it's important to understand right before we wrap up the daily utility of Pulsera to replace the radio report, to facilitate communication between EMS and hospitals. There is no cost to that. That is included for free to anyone who wants to use Pulsera. So your EMS agency or hospital could replace that radio report or send the ECGs from the field to the hospital, or even do telehealth from the field to the hospital starting today at no cost. And so that piece, the daily utilization, is free. And that kind of builds that critical communication infrastructure. So when your region or organization or state decide to make a change to the way you communicate for surge events and hazard events, that piece can be purchased. And so that the daily communication platform that is of no charge can scale up to meet your needs. So great points, everyone. Thank you so much to Hillary and Stein. And I'm going to pass it back to Kinsey to wrap us up.
Awesome. Well, thank you so much, Brandon. Thank you, everyone, for joining us today for such an insightful discussion. Brandon and Kate, thank you for guiding the conversation. And Hillary and Dr. Bronski, thank you both for sharing your expertise around leveraging technology and hazard response.